Dr. Oksana Sawiak practices in Mississauga, Ontario. She's a graduate of the University of Toronto, the first woman master of the AGD in Canada, and the third dentist there ever, correct? Yeah, first woman master ever. Pardon me. So that's fantastic. And the third dentist in Canada ever there. She is an accredited member of this group here, the chair of the Biological Periodontal Therapy Committee, and is going to speak today on this. So let's welcome Dr. Sawiak.
The AGD disclaimer: I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. Thank you and welcome. The butterfly is my logo, and probably those who know me know that I wear them quite often. The reason is that it represents not just beauty, not just gentleness, but also resurrection and renewal and transformation. With the Perio program, we have a chance to do all that with our patients. There's no doubt in anybody's mind that periodontal disease is an infection. I don't think after hearing Dr. Baldwin that you did. And those who have attended Dr. Kennedy's Perio 101 or my previous lectures know that there are various bugs that are the cause. Even the mainstream periodontal world now admits it, but still does not admit that it is an infection affecting and involving the whole body. Nor does it admit that periodontal disease is contagious. The prevailing belief is still that calculus and plaque are the cause in many cases. Let's go through the common scenario. New patients come into the practice through the hygiene department. Records are taken, chartings, assessments are done, the patient is cleaned up. Before being presented to the almighty doctor in an acceptable format, just like the baby that has to be cleaned up before it's given to the daddy, so that the dentist does not have a chance to see the presenting picture, the pus, the inflammation, the calculus, etc. Can we see any problems with that? Well, many offices are doing this: scaling pussy, bloody, swollen mouths, planing the roots to make the surfaces smooth and taking the cementum off, frequent scaling recalls into perpetuity in periodontal offices or in our offices, and of course stringent home care protocols with repeated admonishments and irrigation and antibacterial chemicals after the scaling, and in many cases pocket reduction surgery once everything is cleaned up. Is that better? Do I have to keep my chin down? This isn't working as fast as I wanted to. There we go. Okay. So then what concerns me is that every time we touch the gum with a scaler, with a prophy cup, with a toothbrush, or even with food, pathogens are transported into the bloodstream. And granted that periodontal disease is an infection, that scaling is done around the sulcus of the tooth, that the sulcus goes directly into the bloodstream and accesses every organ and part of the body. How come we don't cause subacute bacterial endocarditis in everybody? I think we do. Young people are having endocarditis episodes now. We are getting sicker and sicker as a society, even though our lifespans are longer. We used to premedicate our cardiac patients for any procedure that invaded the sulcus. Now, the Heart and Stroke Foundation says there's no sense in it because every time you use a toothbrush, it's the same thing. It's not that it doesn't require the protection of premedication, but it just is one part of the whole picture. We used to premedicate people with all kinds of medical histories. Now, I'd like to see us protect the healthy patients in any way we can. We heard this morning that periodontal disease can and does raise the C-reactive protein, and it's a marker of cardiac disease. Brushing alone can raise the circulating pathogen level in the blood. And what about scaling? And what about ultrasonic scaling? If brushing a periodontally infected mouth can lead to heart problems, then ultrasonic scaling not only puts the patient at risk, but ourselves and our hygienists by broadcasting it all over the office. Calculus and plaque are the result of an infection, not the cause. Bacteremia, mycosepticemia, and parasitemia, which all spells septicemia, happens if we scale an infected mouth. So if I get nothing else across today, I hope that you will take this point to heart. We are dealing with a whole body infection with its source in the mouth. It is catching and it makes the whole body sick, not just the mouth. And you heard that this morning with Dr. Tom Baldwin's presentation. So before you pick up a scaler or prophy cup, you diagnose the presence or absence of infection under a microscope. If the slide shows little motility or only a few bacteria, irrigating first may make the scaling safe. Otherwise, why risk it? Why not just get rid of the infection first and then scale? Plaque is the result of poor hygiene, is what the plaque theory said. That the more plaque, the more periodontal disease. Composition of plaque is bacterial. In the last century, even though it was during my lifetime, periodontal treatment was guided by this plaque theory. And most of the bacteria they found were something you and I never learned about in our bacteriology course. There are more exotic names for them and more of them. Not flossing often enough or hard enough, not brushing correctly, not using oral irrigation. The plaque is a cause of the periodontal breakdown and prevents readherence of the tissue to the tooth through mechanical interference. That was what they thought. But now, when you look at it as a whole body infection, it's different. It was also believed that bone once lost was irretrievable, that only teeth were affected by the gum disease and that there was no systemic effect. It was incurable, only controllable, that it was the beginning of the end for people. And it also shows us that these systemic effects don't stop in the heart or the thyroid or in the blood vessels or even in the stomach. In the 1980s, these were all considered normal flora in the plaque of a healthy mouth. Strange that it was never considered the normal flora of the tonsils, of the bronchi, of the esophagus, or of the stomach. Dr. Phillips, who's a Toronto parasitologist, assured me that there is no such thing as a harmless parasite. In the 70s, bacteria was suspected in causing periodontal damage, but plaque was still the cause, and plaque was still the patient's fault. And chlorhexidine became the topical anti-infective. Many of us remember stained teeth, and I don't remember how toxic it was. It's still used widely by periodontists and implantologists in various preparations. Antibiotic therapy in the 1980s started to be proposed, presumably to fight gram-negative bacteria. Clindamycin and tetracycline were being prescribed. They were being prescribed without culture, without a microscopic slide, without a diagnosis, and a hit-and-miss approach, with no scientific validation. With this kind of use, people were being medicated. The dentist was told by the periodontal lecturer to use the clindamycin, to use the tetracycline, but they didn't know why, and they didn't really know whether it was being effective unless the patient healed completely, and they rarely did. So they would try this antibiotic, try that antibiotic, some curettage, some root planing, and if that didn't help, we'd do some dental circumcision. Many are still at this stage in their dental offices because cultures and microscopic diagnoses are not being done before antibiotics are being prescribed. And periodontists consider a pocket of 6 millimeters out of the realm of expertise of the general practitioner. Did you know that? That was an AGD letter to all general practitioners. Yet many patients, if they return to your office from the periodontist, still have pockets which the periodontist is saying he or she is maintaining. The person that showed me the scientific path was Dr. Trevor Lyons, and you've heard of him today. He spoke to this academy before I became a member, and I heard him speak in the late 70s. Following the teachings of Dr. Barkley, he bought a phase contrast microscope in order to motivate his patients in oral hygiene and have them accept an oral hygiene program that Dr. Barkley was teaching. He proceeded to take slides on every single patient that walked in his office. And with the phase contrast microscope and a monitor, he would show them the picture of their plaque. He would identify white blood cells, red blood cells, bacteria, fungi, parasites, and then put them through the Barkley 5-day oral hygiene program, then scale them, then monitor and scale every 2 to 3 months, every 6 months, whatever the patient would let him do. Then in February of '78, a long-standing patient of his, a lady in her 30s, came in and said, "My gums are itchy, and something's wrong. This tooth has moved." So she, when he took a look at it, he saw the pus from around the tooth, and he felt that the slide would show him what the problem was. Anyways, so he took a slide and found that there were a couple of things that looked like mice running around on the slide, and a few amoeba, lots of white blood cells. But because she saw this on the monitor, she said, "Yuck, what is that?" And he said, "That's normal flora." And she said, "I don't care if it's normal, I don't want it there." And he said, "I don't know how to get rid of it." So she said, "Find out." And he went to his medical colleagues, found out that metronidazole was a good antibiotic for bacteria and for parasites. So he put her on the metronidazole. She got better, and he then was able to move the tooth back into place, and the bone did not recede. There was no remaining problem with the tooth. So what is an amoeba? It is an obligate parasite which means it needs a host to survive. It likes a pH of 7 to 7.5, but survives as low as 5.5. It is anaerobic. It does not need oxygen. It is a lumen dweller. It likes dark, deep places. And also it's found in lungs, tonsils, esophagus, stomach, intestines, cervix when IODs are used, in the uterus, and has been found in the bone marrow of arthritic patients. Interesting. It acts like a Pac-Man, actually. It dissolves tissue where it resides, specifically the periodontal ligament. It ingests the erythrocytes and feeds on the hemoglobin. It sucks the nucleus out of the leukocyte. So, like a Pac-Man, it chomps away at the periodontal ligament and leaves our blood cells without the energy of the hemoglobin. So read anemia. Takes the white blood cell, leaves it a dead shell that is incapable of fighting microbes. That's why our body has such a hard time fighting this. Now, yes, the terrain is very important, and that other speakers will be speaking about. Right now we are talking about just the mechanism that infects us. The amoeba can stay in the oral cavity in the throat without symptoms for an extended period of time. Whenever I've taken a slide, I've sometimes been very surprised that a very healthy looking mouth will have amoeba. Outside the body, it can remain dormant in cyst stage for up to 40 hours. It can remain viable on a surface for 48 hours at room temperature, and it can withstand freezing temperatures for 18 hours and can survive 20 minutes or 45 degrees Celsius. So it's not a ninny. It's something that is common. If we know that 80% of North Americans have Perio disease, 80% of those have parasites. So if we find a particular organism consistently in a disease state, and if elimination of that organism brings about resolution and healing, it seems obvious that the organism must be the key. Dr. Lyon's recall population had 62.5% amoeba, and 4.5 of them also had Trichomonas tenax. And when you have both of them, usually that's a picture of ANAG. So the weight of evidence points very strongly to the likelihood of amoeba being the primary periodontal pathogen with systemic manifestations in destructive periodontal disease. If your tonsils were infected, the surgeon would be deferring your tonsillectomy. But in dentistry, the first thing we did in the past was we scaled, often with cavitrons. Little wonder people so often felt like they had the flu after a scaling appointment. Periodontal disease, heart disease. Are we not listening? Are we not hearing? Dr. Vimy, the founder of this academy, said, advancing destructive periodontal disease, periodontitis, necessarily involves oral parasites. And those are Entamoeba gingivalis, Trichomonas, or Candida, which is a fungal parasite. Systemic symptoms of parasite infections. There they are. When you take a medical history, until you get your microscope, you can take a look at these and surmise whether they have a parasite infection too. It doesn't look like a problem limited to the mouth, does it? Night sweats are very, very descriptive of a parasite infection. Itchiness around the anal area, bedwetting, allergies, bruxism, all these things are very common symptoms of parasite infection. After years of doing this, even without seeing the slide through the microscope, I can often tell what type of infection we are dealing with when the patient presents with some of these clinical symptoms. Bacterial infections usually, I'd call it more gingivitis-like. Redness, a little bit of calculus, some swelling, delayed bleeding usually. Topical hygiene efforts usually succeed in controlling the symptoms. Parasites usually show up as swelling, spontaneous bleeding, sometimes during chewing. Plaque calculus is usually heavy. You'll sometimes get blueness of the mouth. Halitosis is very common. It smells like mothballs. In advanced cases, you'll smell them right across your desk, or sometimes right across a room. Pockets are starting to form. There's often tooth mobility. And even though they brush, floss, etc., an hour or two later, the plaque is there again. They say, I've got sweaters on my teeth. This is getting away from me. And fungus, which is Candida albicans, has a very specific picture to it. It will have a very adherent orange or black plaque. It's almost gummy. There will be recession. There will be quickly progressing root decay in many cases, and very little swelling or bleeding, but a white coating on the tongue as well. So, are you going to treat all these infections the same way? How do you know for sure which infection it is? As Dr. Baldwin said, if you don't have a microscope, you're working blind. And if you can take a slide of the plaque, you have a diagnosis. You mature the plaque for 24 hours by following a pre-plaque collection protocol. And this is important because sometimes people have brushed very well, flossed very well. They have temporarily hidden the cause of their infection. You collect a sample from a likely area, not just from specific areas that are predetermined. If you take a look at a panorex and you see bone loss, that's where you go. Or if you see redness or swelling, that's where you go. And then do a microscopic analysis identifying which pathogen you're dealing with. So how do we get infected? Where do they come from? Husbands, wives, any adult family member, personal attendants, cooks, restaurants, salad bars, buffets, utensils and dishes that are not put through a dishwasher, shared food like in a banquet situation, or cigarettes or lip gloss, toothpaste. We often use the same toothpaste as a family. Shared telephones and keyboards. Crowded public places, especially sealed public places. And many of my air hostesses really fight gum infections frequently because they are in an area of recirculated air, close to people, many people. They cough, they sneeze, and so they constantly have to fight with that. And of course, poorly maintained heating and air conditioning systems, like the Legionnosis situation in Philadelphia, was it? So as we can see, it's hard to avoid getting infected if you are in any way predisposed. And your terrain will predispose you. For instance, if you are very tired or you scratched your gum on that crusty bread, or you forgot your toothbrush for that weekend getaway at the cottage, and someone coughs in your face. Bingo. Got it. Patient significant others, as I mentioned, are frequently a source, so we bring them in for testing. If they had a sexually transmitted disease, both partners would be treated. Mouth infections disseminate much more quickly and much more easily. Why would we treat only one partner? If they have a housekeeper cooking for them, like I did, and they are infected, or you live or work with any adults sharing foods or utensils or dishes, you might get infected and reinfected. And as we said, restaurants, salad bars, shared dishes. Kissing your dog or outdoor cat is another no-no, because you're going to get the parasites that they've picked up from the ground or from feces of another animal. And even if you deparasitize your animal regularly, if they go out, they can pick it up. So, microscopy. I like to keep to the KISS principle. There. Microscopes scare many dentists. It seems the hygienists and assistants don't seem to spook quite as readily as we do. And it is really not difficult. If you get the basics straight, you will be able to do very well. Choose a microscope company that will support you without gouging you. Local is ideal if you can find them. They're not complicated. If you want to save some money, go on eBay. Get a phase contrast microscope that's used. Very little goes wrong with microscopes. They're not that fragile unless you drop them or something like that. And make sure that you learn about aligning it and collimating it. And if you move it, you need to know how to adjust it. But it's like any other piece of equipment that you have. Please turn up the objective so that you don't scratch it when you slide the slide underneath. It's one thing that can ruin your objective. Use gross focus adjustment to bring it back down, and then the fine focus knob to clarify the picture. Keep supplies like a paper and pencil close by. If you're digitally gifted like Dr. Kennedy, you can attach the microscope to your computer and have a record of the slide on the patient's chart. This is what I give to my patients to mature the plaque. I don't want them brushing for 24 hours before the slide. Use only water rather than any chemicals or herbal preparations. No alcohol for 24 hours, no vitamin C or antioxidants, no drugs if possible, and don't eat excessively spicy and salty foods. That part I need to change because many, well not many, but a few patients have come in and said, I'm so hungry, you said I couldn't eat. And so we hand this out with instruction sheets to the patients. And the reason that we need to mature the plaque I've already mentioned. You need to see the evidence before it's cleaned away. We used a colored stock. We use a colored stock for this sheet so that when the patient calls and says, or when we call the patient to confirm the appointment, we say, make sure that you follow the instructions on the yellow card. That way they know which card you're talking about. And yes, assure them that they can eat. Slide preparation, you harvest saliva from the floor of your mouth. There are some people that use a chemical or some saline or some other preparations to prepare the slide. If you use saline, think of what happens when you have a leech attached to you. What do you put on it in order to get rid of it? Salt. So salt will kill a parasite, and you won't see the parasite. The saliva is the most friendly environment for seeing the parasite or the bacteria. Some people will seal the cover slip. I don't see any value in that. As a matter of fact, if I want to try out a new product on whether it will kill my pathogens, I can put a drop of it beside the cover slip. It will go underneath and will show me the results. You drop the saliva onto your slide. You put the plaque into that drop. You push your cover slip down until you see a uniform layer. It's very important that you're looking at one layer of cells only. If you have multiple layers, you will have a problem seeing what you need to see. And I usually burnish the cover slip down a little bit. If you have any food particles or calculus, you can break your cover slip, so be careful that you don't collect those. And this is what we find. So these were considered normal flora in the plaque of a healthy mouse. We now know that they are all pathogens and that they are not found on the slide of a healthy mouth. I do not find these when the mouth is healthy. This is the microscopic analysis plaque page or a little sheet that I have for people. I have this beside me to just record what I see under the microscope. Actually, my assistants and my hygienists do this, but I want to see that when I'm going to give the diagnosis to the patient. And we put a plus for some, 2 pluses for a lot, and 3 pluses for wow. And in some cases, there will be 5 pluses. So make sure you record your findings and bring it to that chart so that the assistant records it. One other hint. Amoeba has a circadian rhythm. It likes to sleep in the morning. And it likes to feed and be more active in the afternoon. So to increase your chances of identifying parasitic infections, book your slides at first from 3 to 5 p.m. You will find them more easily. This is the prescription that we would use for the metronidazole. There is always something by mouth and something topical. The drugs that Dr. Lyons found effective for parasites. And the regimen includes the pills and compounded paste that is applied topically. If there is no time for an herbal protocol, or if the patient is having cardiac surgery, for instance, or if a patient cannot or will not comply, we still use that. The metronidazole can be very hard on the digestive system. Herxheimer's reactions are frequent, and no alcohol is allowed with this regimen because it acts like antabuse and it can really make a patient sick. So if they forget that they're on metronidazole and they have a glass of wine, they'll certainly curse you. This is for fungal infections. We could use nystatin, and both have topical and general effect. The oral suspension and the nystatin powder can be used. The powder is useful under dentures or can be mixed with aloe jelly and applied to the gums. Try to get the stuff with without the talcum powder in it. Some dentists also find vaginal nystatin suppositories very useful as lozenges, especially in institutional situations where elders don't have a good oral hygiene. They don't have, they're on a lot of drugs, their diets are poor. This might be an answer to reduce their tremendous rampant decay and their gum problems. I find that Candida does not get cured unless treatment is continued for at least 18 weeks. The reason is that the only stage of Candida that it can be destroyed at is the bud stage. And since Candida has a 6-week cycle, we need to keep treating through 3 cycles in order to get all the buds. And one of the problems with a lot of medical treatments of Candida and fungal infections is that they don't do them for long enough. And so they come back and back and back. And cleaning it out of the gut is also very important, because if it's not cleaned out of the gut, it certainly comes back. The diet, Candida diet, is also very important, or you won't get rid of it. So the weight of evidence points to the strong likelihood that Entamoeba gingivalis being the primary periodontal pathogen with systemic manifestations in destructive periodontal disease. If you wish to read more on this subject, Dr. Lyon's books are available at the DAMS book table. This book is out of print, so once they are gone, they will no longer be available. If this is the only pearl I leave with you today, I will have succeeded in my mission today. Diagnosis before treatment. Don't pick up a scaler. Don't even irrigate until you know what you're after. So, if there are questions after today, call me, email me, snail mail me, and do I have time for questions? Where's the timer?
Just make sure you repeat the question.
Okay. Yes.
Oksana, on a clinical application, I'm getting a little bit away on technique, but do you have your hygienist do the full mouth each time, part of the mouth each time, in order to avoid any cross-contamination by sitting a patient on one side?
Come to my next lecture. He's asking whether I have the hygienist do the whole mouth at a time or part of the mouth. This is a whole mouth, whole body infection. The whole mouth gets done. And since I find that once you get rid of the infection, there is no pain with scaling, I don't need to do quadrant injections or anesthesia, so the whole mouth gets done. Any other questions? Yes? Slide versus culture. I will also be discussing that in the next session, but a slide I can do right there and then, and the patient knows right there and then what I'm looking at. They can see it. I can involve the patient in their treatment much better. With a culture, it seems to be something that is sent away and somebody interprets it and then sends me a report. The patient doesn't own it quite as much. I think that there is room for culturing, especially when there are some esoteric things. But to me, whether they're esoteric or not, if they're a bacteria, there's one treatment, more or less. If there's fungus, there will be another treatment. If it's the parasite, there's another treatment. And so I don't know that it's that important to know the exact name of the bacteria or the fungus or whatever. Being clinical, hands-on, my interest lies in treating the patient and not knowing exactly what the name of that bug was. Did I answer your question? Okay. Blanche?
You didn't mention anything about natural herbal.
That's in my next session.
That's the next one.
Yeah, that's called intermediate. Yes, sir.
When there is a parasite in a slide, is it easy to find, or it's like, 1 in a million? Do you have to go hunting for it, or is it like right there?
When you are looking at a slide like Dr. Baldwin mentioned, you look for activity. And the more active the slide, the more likely there is a parasite. And then I will look on the edges of the plaque, almost what I call in the lakes district of the plaque, and that's where you will find them. They are very easy to identify because they're big. They are very easy to... Oh, in the lakes district, yeah.
And just this might be a cute thing. We tell our patients that if you're looking to count monkeys on an island, it's very difficult to see the monkeys if they're in the trees. And what you have to do is you have to go to the beaches and see how many monkeys are on the beach. If you see tons of monkeys on the beach, you're almost guaranteed that there are tons of monkeys in the trees.
Dr. Grube suggested that you explain it as if the monkeys on the beach, if there are monkeys on the beach, there will be monkeys in the forest as well. And very true.
Do you want to try and show that video?
Yes, that would be a good idea. What you see there running around, looks like a mouse feeding, is Trichomonas tenax. It is found in vaginal infections. That's why women get flagell. This is what they get it for. This is an amoeba. You can see that it's large. The only other thing that looks like that, similar to that, is a white blood cell, and that's what you have underneath there. Where's my... Okay, there you see the amoeba dragging a white blood cell with it. And here you have the cocci, the rods. Okay. There's your Trichomonas. This is just a quick video to give you an idea. Flow like this is not a big problem, but this, you have spirochetes attacking a red blood cell. When patients see this, there's no question of compliance. No question. Like, I'm sorry, but I didn't know I had this. Can my daughter get it? Can my wife get it? Where did I get this? Your job is almost done. And this is all done by my hygienists. They instruct the patients on plaque, pre-plaque collection. They collect the plaque and they give them the instructions. Yes?
Being that if you have this in your oral cavity, you have to grab a lot.
Yes.
And you're seeing maybe a new patient. How do you, you're coming to use dentists, and so you're introducing them to this, and then you're telling them it's all throughout their whole body. I'm thinking that there must be some limitation that they're expecting from us as dentists, or is there a place where we cross over the line, or how do you present that?
The question is, how do we present this as a whole body infection that it's not just in the mouth? I tell them it's in your mouth, and then they ask, could it be elsewhere? And I said, yes, because you swallowed. But I am treating your mouth. That's the way I present it. Any other questions? Yes? Can these organisms cause lichen planus? I have found lichen planus is, again, a symptom of breakdown. So if you have enough causes of breakdown, you will end up with lichen planus. This can be one cause of breaking down the immune system. So it's not just one cause, one effect. It is a conglomeration of effects and causes. Yes? What would a clean slide look like? No motion, no activity. Generally no white blood cells, no red blood cells, no amoeba, no parasites of any kind, no fungus of any kind, and no bacteria of any kind. It's dead quiet. Second question. That's correct. If there are no bacteria in the mouth, there shouldn't be any decay either. That should be right.